This program is brought to you by Emory University.
Good morning, everyone. Welcome to the delayed first cardiovascular grand rounds of the season. The talk from last week was actually me. It's going to be rescheduled for October as we try to catch up because of the weather. So today we have Chandon Devireddy with us, and all of you know Chandon is a longtime faculty member here at Emory. Did his, let me get all this right, medical school at Michigan, internship residency at Duke, and fellowship in general cardiology, interventional cardiology here. It's been on faculty since that time, and Chandon's interests are in interventional cardiology and structural interventions as well as peripheral interventions, and he's had a long-standing interest in renal denervation, and this is an interesting topic who we sort of thought was put to rest a few years ago, but apparently there's some new ideas, and Chandon's going to update us on renal denervation.
Thank you, Bob. Got a whirlwind of information to go through with you today. Quick disclosures, I am on the Scientific Ad Board and Data Safety Monitoring Board with Medtronic. We will also be discussing some techniques and devices that are not yet FDA approved. Objectives for this morning, number one, to go through a review of the mechanism of action of catheter-based autonomic nerve modulation. Number two, to review some of the past evidence of trials that have attempted to study renal denervation for the treatment of hypertension, and then to also go over novel and ongoing studies that are trying to clarify the potential role of these catheter-based treatments in the armamentarium to lower blood pressure. Hypertension, I don't need to tell you these numbers, but as you all know, is a major health burden, especially here in the Southeast United States. Dramatically increases the risk of dialysis, heart attack, and stroke, and long-term ends up increasing our overall national healthcare budget by a huge amount, and now is increasing in its prevalence around the world. This is old data now from a meta-analysis published in The Lancet over 10 years ago, which looked at just what the effects would be if we lower the blood pressure by a small amount, 2 millimeters mercury, and the long-term downstream 1 decade later is a significant reduction in stroke and ischemic heart disease mortality. So the impetus is on us to try to lower the blood pressure for our patients. More recently, there's been some question about whether there's even a paradigm shift in how aggressive we should be in lowering blood pressure. The SPRINT trial was designed as a massive study, almost 10,000 patients, to lower blood pressure to a lower threshold. And this study was actually terminated early due to reduced mortality. There's been a lot of debate about methodologic concerns of how this trial was designed and analyzed. But the bottom line is, in patients who were treated to a more aggressive blood pressure goal, essentially a systolic blood pressure goal of about 120, which took on average 3 medications. You can see here the patients in the intensive treatment group here in the yellow bar. These patients in the intensive group had a lower mortality out several years, with a number needed to treat to prevent mortality of 90. So this raised a lot of questions about whether we should change the guidelines. There's been subsequent data, and one of the interesting things about this study is how patients' blood pressures are measured. They had to go in a room, kind of press the button themselves, and employed a methodology very different than what's been used in prior studies. Another trial that came out that muddied the water further was HOPE-3, which looked at a very low-risk group, also looking to see if the initiation of candesartan and a thiazide could reduce heart events. Now, in the overall outcome, the result was somewhat mixed, but when you split the blood pressure group into tertiles and had a cutoff of over 140, about 140, 143 in blood pressure, that patients that received antihypertensive therapy did do better in reducing the composite outcome of CV death and the remainder of these outcomes. So again, there is increasing data to suggest that lowering blood pressure even further in groups that have been considered lower risk to begin with may be of benefit in reducing long-term outcomes. So let's put patients on medicines. Well, of course, that's great, but the problem is, as you all know, if you're seeing patients in clinic, that patients don't like taking their medicines, and poor adherence is associated specifically with poor outcomes. Here in the bars here, this is patients who were very compliant in the green bar, but then as you go to patients who are less compliant, taking their medications less than 40% of the time, the incidence of cardiac events is significantly higher. That's not a surprise, but the problem is patients in our clinics don't take their medicines many times. What leads to this? As you can see here, patients that are more adherent typically will have more social support at home. Surprise, surprise, they have insurance coverage. Patients who are non-adherent typically are younger, they feel more invincible, may have psychosocial issues or social issues at home. And this one is one I'd focus on, complexity of therapy. There are blood pressure regimens that have simplified our ability to take meds, combination pills, but they're very expensive. There are some simple combination pills, but not as, there are some triple therapy pills, but all of those still are quite expensive for our patients. So patients who are being asked to take medicines sometimes once a day, twice a day, even 3 times a day in the case of hydralazine is a very difficult regimen for some of these folks to take. This is interesting data in a specialized hypertension clinic, patients who were referred specifically for resistant hypertension. These are patients but providers felt they had put on 2, 3, 4 medications, they weren't getting anywhere, sent them to this clinic, and they did biomarker assessment and assessment of metabolic byproducts of medications, and found that nearly half of these people were non-adherent in some way to their medical regimen. 15% of these patients were taking absolutely nothing. So it's a very complex issue of why patients don't take medications, but the realistic notion is that, you know, for almost a majority of our patients, there's some degree of noncompliance going on in people who are on antihypertensive therapy. So our medications are our only option. They are the established mainstay of therapy. We have excellent data, medicines that are much easier to take in terms of side effects than they were 50 years ago. But experience and data demonstrate that noncompliance, as I just showed you, and poor tolerance are real issues. So the question I would pose to you is, what would the ramifications to our health system be if we could treat underlying hypertensive pathophysiology in a different way that was potentially more durable and did not rely on pills? So with that thought in mind, I'll take a little bit of a segue and go over the sympathetic nervous system in a very quick review. This goes back to basic med school pathophysiology. The essential, it's a busy slide, but the essential role of the autonomic nervous system is to maintain homeostatic balance in various physiologic systems. And that works great when it's working well, but for whatever reason, in 2017, in the age of diet soda drinks and increasing body mass index across the world, this modulation and homeostatic balance seems to be awry in many patients. It's been well known that the kidneys have a rich plexus of sympathetic innervation that has been described for almost 200 years. These are abundant and typically follow tracks along the arteries and arborize from the aorta toward the kidney distally. So with this knowledge in mind, and again, the interesting number I would point to is the very bottom of the screen. This is published in 1953. Some surgeons went ahead and said, let's take out some of these nerves as a method of treating hypertension. And the patients who were stratified in different groups, group 3 and 4 being those patients who had more end organ damage from hypertension, once they underwent this surgery, ended up with long-term mortality that approximated patients that were in a much lower end organ damage risk group. So it was shown at that time that lowering blood pressure was possible, was efficacious through this type of surgical approach, but who wants to have their abdomen hacked out and have nerves stripped off with lots of morbidity if you don't need to do that? And as we underwent a pharmaceutical revolution with the onset of thiazides and other medications, this type of approach really disappeared. But the principle remained, and if we think about it, there's innervation that comes from the kidney that goes back to the brain, and in a feedback loop, the brain has sympathetic signaling down to the kidneys, which regulates many functions down to the level of RAS activation, sodium retention, and excretion, as well as overall renal blood flow. And then as signaling goes back, there's been a lot of interest in potential ways that this feedback loop may influence the way that insulin resistance is modulated, potentially atrial fibrillation, congestive heart failure. There are some ongoing studies around the world in systolic and diastolic congestive heart failure with renal denervation. In the United States, there are active trials with this in atrial fibrillation. for the means of this talk, it'd be a little bit beyond the scope of what I can reach in an hour, so I won't go into those studies in detail. Now, in addition to the renal nerves, just to take another sidetrack here, there are other sites of regulation in sympathetic tone, especially in regards to blood pressure. The carotid baroreceptors being one. These are located in the carotid sinus, which stretch sensitive fibers, measuring pressure-induced strain, and then through the carotid sinus nerve, issuing feedback to the posterior hypothalamus. What results is potential dilation or vasoconstriction, heart rate modulation, and an effect on overall cardiac output. We'll go into why this may be important later on. So how did catheter-based renal denervation therapy come to be? Well, as I mentioned, this physiology has been long described, and as medical technology has continued to advance, the question, given the higher incidence of hypertension over the past several decades, could we approach these same nerves in a way that was minimally invasive without any type of major surgery? These nerves tend to arborize just outside the adventitia, and with different technological means, we have the ability to induce damage to these nerves without damaging the internal intima and media of normal vessels. So the goal here is to essentially destroy and silence these efferent and afferent nerve fibers that are traveling between the kidney and the brain, and thus hopefully put some improvement in the abnormal mechanisms of RAS activation and in sodium retention. There were two main studies that really generated a lot of momentum for renal denervation as a treatment option. Some of you may be familiar with these. HTN-1 was kind of a preliminary feasibility trial that was done just a few patients in the US, most outside the US. Simplicity HTN-2 was entirely outside the US, and these were all based on office blood pressure. So HTN-1 had drops in blood pressure going out to a year of over 25 points systolic. HTN-2, which was a larger trial, looked at 6-month office blood pressure, which had a blood pressure drop of 32 points compared to the control group. So this trial sailed 1,000 ships in regards to interest in renal denervation as a therapy. People were talking about stock options and Medtronic and starting up venture capital-based companies, all with the interest of trying to get the next best thing to find a way to affect renal denervation with some type of new catheter system. This was given CE approval in Europe and in different countries around the world, and was already being used as a commercial therapy for hypertension, except in the United States, where we were sometimes laughed at by international operators saying, well, your FDA is slow, you guys are missing the boat. And we kind of huddled in our corners and rocked ourselves to sleep. Until HTN-3 came, and then we were very excited, and we said, okay, finally we can catch up with the rest of the world and try to lower blood pressures with this amazing catheter-based device. And this trial was designed in a way that was much stricter than the outside US studies. Now, one point I didn't mention was that the OUS studies employed a control group that was essentially a best managed medical therapy group. There was some criticism of that design. In HTN-3, the intention was the control group has to be stricter, and the idea was to randomize renal denervation versus a sham-controlled procedure, so that the patients, in effect, would not know what therapy they received. This was a large study. 535 subjects were randomized. It was a 2-to-1 randomization assignment. All patients underwent renal angiography and were randomized on the table with iPhone earbuds on and blindfolds and lots of sedation. It was a very interesting trial to participate in terms of learning how to do a good sham control procedure. The Europeans thought we were crazy. They said this is unethical, there's no way you should do this. And as far as who was allowed to participate in this trial, it's a little bit of a busy slide, I apologize for that, but this was a much sicker group of patients than in the prior two Simplicity HTN trials that had been designed. Patients had to have an office blood pressure over 160 while taking full maximal doses of at least 3 medications, one of which had to be a thiazide diuretic. They could not have had medication changes prior. We saw them again in 2 weeks. to again check their systolic blood pressure, and they also had to have an ambulatory blood pressure monitor at 24 hours with an overall blood pressure average of over 135 systolic. If they met all these criteria and their GFR was over 45, patients then went to the cath lab, underwent renal angiography. The presence of any accessory renals or any significant renal stenosis that eliminated our ability to do safe renal denervation were eliminated. And these patients, after randomization, were followed, and then at 6 months after their blood pressure was obtained, they were unblinded. So with a lot of hoopla, we were waiting for these results to be presented at some international conference, and then a conference call went out announcing that the results were going to be announced before any scientific meeting. So we said, okay, that's interesting. The safety endpoint is described here. They had a pretty open performance goal of what they considered safe. The study, beat that by a long shot. There was really no evidence of any problem or danger in performing this procedure in patients other than the routine things that you would see with a catheter-based approach from the femoral artery. A little bit of bleeding here and there, but nothing on the order of renal dissection, perforation, or trauma to the renal arteries. Overall serum creatinine was stable and unchanged compared to the control group. The problem comes in the next slide. So the blood pressure in this blue bar dropped 14 points systolic after renal denervation. Well, that's pretty good compared to medication. The problem was that the control group had an astounding drop in their blood pressure of almost 12 points. So we should prescribe placebo to all our patients. Well, that's what a lot of people joked about after this trial was performed. This is published in the New England Journal of Medicine. So the overall difference in blood pressure was just over 2 points systolic, and the pre-specified superiority margin was defined as 5 millimeters by office blood pressure. So you could hear the wind kind of, coming out of the balloon at this point. And some people say, well, what about 24-hour ambulatory blood pressure monitor? That's what we're really interested in. That's the one that's more reflective of cardiovascular outcomes. Again, the renal denervation group did drop. They dropped almost 7 points, which is a pretty healthy number for 24-hour ABPM. But the control group, again, had a fairly rich, almost 5 millimeter point drop in their 24-hour ambulatory blood pressure monitor. So even by 24 ABPM, this missed the 2 millimeter superiority margin as well. So there were a lot of clinical trialists and people that kind of came out of the woodwork saying, we told you so, lots of whom had not told us anything before, but were very quick to tell us they told us so, and that this was all placebo, there was nothing to it, and we should go back to 4 or 5 medications in these type of patients. So some of us waited even longer and said, well, there was trends that showed that blood pressure continued to drop beyond 3 to 6 months out to 12 months, and could we see the potential clinical effects later? And there was a further drop in blood pressure from 15 points to 19 points in patients in the 6 to 12 month group. And then patients who had been randomized to the control group at 6 months, if they were still hypertensive, had the option of getting renal denervation therapy. Those patients were followed for 6 months, and they also saw a healthy blood pressure drop of 17 points. Now, this yellow bar is not the control group. This is their diastolic blood pressure. The next slide shows you the patients that did not cross over, who were still in the control group, and wow, they still had a blood pressure drop as well, systolic. A very healthy blood pressure drop. So there was, again, no significant difference between treatment group and control group in this trial. So what is going on? Was this the most expensive clinical trial to assess placebo effect ever? Possibly. But I'm going to go through and dissect HTN-3 a little bit, and there's lots of different analyses that have been performed of this if you want to read more detail about it. But one of them was technical. The study was enrolling fairly slowly in the beginning, and the sponsor, Medtronic, I think in their desire to, who knows what, meet their shareholders' expectations or just try to get the device on market, they really felt that this was going to be a slam dunk based on their European and outside US data. They opened up the trial to a lot of other centers. So the problem is, you can see here, the majority of proceduralists did 2 or only 1 procedure in the entire study experience. There was no ramp up or run-in phase. Basically, the first procedure you did counted towards outcomes in the trial. So the majority of these procedures were being done by operators that had very little experience in doing any type of renal denervation. At Emory, fortunately, we were up here at the other end of the spectrum. But this is one area that the Europeans were very critical of us, because they said, look, we've been doing renal denervation for a long time, and you can't run a clinical trial with people who have had no experience in doing the procedure. The other question was about dosing. So this is a sub-study we were fortunate to participate in, and the orange bar shows patients that had no full 360-degree concentric ablation done in either right or left kidney artery. The yellow bar shows patients who had at least one kidney artery that had a full 4-quadrant ablation, and the darker bar here shows patients that had full 360 ablation in both right and left renal arteries. The problem was that the minority of patients were reflected in the darker bar, but the patients who did get more renal denervation had a much more prominent blood pressure drop, both in office numbers and in their 24-hour ambulatory blood pressure monitoring numbers, compared to those patients who had a much lower intensity in the amount of renal denervation that was performed. So there appeared to be a dosage effect both in office and 24-hour numbers. Now, and again, just to go back, when we were participating in this trial, the sponsors were very conservative in what they allowed us to do. We only did renal denervation in the main trunk of the renal artery, and the catheter was a single tip electrode at the very end of the device, and if it moved at all after the first 30 seconds of your denervation, they just told us, stop, bring your catheter back, go to the next site. They didn't feel that losing 1 or 2 denervation treatment sites would be of that much effect in lowering blood pressure. Whether that bit them a little bit in the end remains to be seen, but we'll kind of discuss that a little bit more as we go further on here. So again, dissecting HTN3, one big issue was the way medications were administered and monitored. So the issue is that many patients during the trial were actively changing their medications, which we felt was a big no-no. In our patients at this site, I can tell you maybe one patient had a medication change. We felt that that was not allowed, but when you go back into the data, it looked like a lot of other centers were having to adjust medications for whatever reason. The other problem is that there was no measurement of compliance or adherence to medication therapy, either by any formal survey, biomarker assessment, pharmacy, prescription monitoring, and this was really completely uncontrolled as far as a variable. The alternative solution that was conceived after reviewing HTN3's data was, could you consider the pharma trial model of obtaining off-medication data, of taking patients off their medications so you kind of eliminate the confounders of patients taking different medicines in different ways, and to at least see if there's any treatment effect in patients without medications. And there's been many studies that have demonstrated the safety of taking patients off their medication short-term to try to measure a treatment effect. Another alternative was to standardize a drug regimen. Could you ask patients to be on the same medicines, or even administer that medication yourself, so you hopefully know what they're taking and they're not taking one of the 20 or 30 different potential med regimens that are out there. And lastly, could you measure drug compliance? And there's a lot of different ways to do this, but this was not done at all in HTN3. So what did this look like? Almost 40% of patients in HTN3 were undergoing some kind of medication change in general. And as you can imagine, this is a big problem, because now you're comparing apples to oranges and everything in between, and you don't know who these patients were as far as their hypertensive burden and what they were really taking. So how do you compare denervation to control group if these patients' medications were actively a moving target during the course of the trial? So there was a lot of grief and depression and companies that folded in the year after this trial was published. Lots of cries of victory from the folks who declared that this was placebo effect, but a few crazy people continued on saying, well, we do feel there's something here to this. And a lot of this interest really continued outside the US, where there had been more experience in doing this, both in clinical trials and outside. And one was an operator, Azizi in France, that conceived this trial called Dener-HTN. And their main criticism of HTN3 was a lot of what we just discussed. So what they decided to do was to take patients, take them off their medicines in a specialized hypertension clinic, and put them on a fixed regimen, as you can see here, of indapamide, either ACE or ARB, and one of two doses, half max or max of amlodipine. Run them in for several weeks on that medication regimen, and then randomize them if they were hypertensive by 24-hour ambulatory blood pressure monitoring to either denervation or by strictly observed medical therapy. All outcomes were done by 24-hour ambulatory blood pressure monitoring, and then they had a very strict protocol of how you would ramp up medication therapy if patients remained hypertensive over their blood pressure goal as defined here on ambulatory blood pressure monitoring. So the goal here was to really try to equalize and control for confounders across patients within this one trial. Their outcomes at 6 months with daytime and nighttime ambulatory blood pressure monitoring showed a drop of about 6 points systolic in the 24-hour ambulatory blood pressure monitoring and denervation in the blue bar compared to the control group in the red bar. And again, this is a little bit different than office-based blood pressure, and a drop of 5 to 6 points in 24-hour ambulatory blood pressure monitoring is pretty good for a therapy. And the fact that they saw this both at daytime and with nighttime numbers reinvigorated the area of interest in denervation a bit, and rejuvenated some of the folks who all along had been saying, well, there's something here. Look at this trial, Dener-HTN. They all kind of showed Dener-HTN as their remaining glimmer of hope that there could be something left to denervation as a therapy. So some other issues with HTN3 was the study population. So HTN3 was different from all the prior studies in that this was a severely resistant hypertensive population, at least defined as severely resistant, taking an average of 5 medications or more, including a diuretic at the highest dosage possible. There was a large African American cohort which had not been seen in prior studies, and there were some analyses that showed that this cohort was requiring a lot of vasodilators like hydralazine, which is a very complex and difficult regimen to take when you're taking medications 3 times a day or more. And there's a lot of questions about whether patients were actually able to keep up with that regimen. It was a very obese population and a lot of variability in geographic and ethnic groups. So another alternative that was proposed for future trials was, can we go away from this issue of measuring office-based blood pressures and not go for these worst of the worst type of hypertensive patients? These patients may be so far along on the risk and disease spectrum that there may not be any hope left for some of these patients who have been on 4, 5, 6 medications for years. And sometimes this may be a marker for patients that actually have pseudo-resistance, that they tell you they're taking 4, 5, 6 medications, but unless you have some way of actually monitoring their compliance, do we know that they're truly treatment resistant? And one other alternative was to try to avoid changing patient behavior and medication patterns overall, and could that be done in a clinical trial? So this is data that Salim Hayek and a number of, at that time, residents, now most are graduated fellows, did as an analysis of blood pressure patients in our own cardiology clinics, where we looked at the criteria of trying to enroll into HTN3, and we found that less than 1% of patients that we see in our cardiology specialty clinics would ever qualify for HTN3, let alone primary care or general medicine. So the question you have to ask is, how generalizable or applicable was HTN3 in general to hypertension patients when you're picking these very few patients that already probably reflect some very individualized and special circumstances when it's such a small proportion of a specialty clinic population. So the goal, as far as the folks who were still true believers in this, was could we move from this extreme risk profile and go to more of a grade 1, grade 2 hypertensive population as defined here in the European guidelines. Now, after HTN3 was published, some additional anatomic data was brought out. This was with the CV Path group, Renu Vermani's group, which actually got some cadaveric data to look at the position in geometric space of where renal nerves travel in relation to the renal artery. When we were participating in HTN3, the party line we were told was, the money is denervating and providing radiofrequency energy at the ostium of the renal artery. That's where the nerves and the ganglia are bigger. They're going to be close to the renal artery. If you don't get good treatments distally, don't worry about it. Come back proximally and really focus your attention there. So that was the prior concept, was that nerves were kind of spread out all along from proximal all the way to distal here. But what Vermani's group showed was that yes, there are lots of nerves proximally, but the ganglia and the nerves are farther away spatially from the intima of the renal artery compared to the nerves as you get out further distally. So if anything, we may have actually been doing the opposite in our instructions in how to perform denervation, in that most of these catheters are offering radiofrequency energy in the area of a 3 to 6 millimeter sort of sweet spot from the intima of the renal artery. And to get nerves at that distance, you're really talking about the distal renal artery as opposed to the proximal renal artery. So again, some questions came up. Was HTN3 effective in actually performing any type of dose effect in true denervation? So from a scientific, technological advancement stance, that didn't change, and the progress of engineering moved forward, and a second generation device was conceived. I didn't even show you pictures of the old device because in my opinion that's kind of old news, but the old device had an electrode just at the tip. So as an operator, we had to position the tip of that electrode manually and to really approximate on a flat X-ray image of where we were performing renal denervation in three-dimensional space at sites 5 millimeters apart from the distal renal artery to the ostium. And the catheter, if you had too much tension, could flip or spin on you, and then you could lose your sense of perspective of where you had started. So a lot of this for the operators in the trial was really best guess. I think we were fairly exact in spacing our treatments 5 millimeters apart, but whether we were truly performing a full 360-degree concentric ablation is in big question, as I had showed you in data previously. The spiral catheter is a second-generation catheter which tried to take some of that guesswork out of the equation. And the way this works is you place a soft wire down the renal artery, advance this catheter, which is compatible with the same type of catheters that we perform cardiac catheterization in terms of size and standard renal angiography. You advance this device on the wire, and as you pull the wire out, the catheter is almost like a slinky spring in that it will either contract and take the shape of the artery anywhere from 3 to 8 millimeters in size. And the gold-plated electrodes are positioned such that they're 360 degrees apart. As you can see here, and looking on FACC at the renal artery here, you can see these different electrodes placed so that you get energy that would go in a complete 360-degree zone around the renal artery. So how do we do this procedure? Just to kind of show you, hopefully these will work. We do baseline renal angiography to show that there is no evidence of stenosis or exceedingly short main renal artery length. The other difference, and I'll go through the trial in particular, but with this device there was early data showing that you could also go into the branches and perform renal denervation into the branch arteries, provided that they were over 3 millimeters in size, to do this safely, at least in a small series of clinical study. The presence of any renal atherosclerosis or fibromuscular dysplasia would be a contraindication. So as we advance the wire out, we then pull the catheter back, and as we pull the wire out, you can see that the catheter retracts slightly and takes the shape of the renal artery. This is further out in a branch, so you don't see it constrict as much as you would see in the main renal artery. So in the right kidney, what we do is in this case, we take the catheter out fairly distal into the branch, then back into the main trunk, and we're not having to steer the catheter as much. The challenge in this new sort of paradigm of renal denervation is getting the device out distally, which is more of a focus, and I'll tell you a little bit more about in just a second. And then pulling it back, but once you get the catheter in the position that you want it, it takes all the guesswork out of positioning the electrode leads. And the console allows you to turn each of these individual electrodes off. You have full control over each individual electrode. You're monitoring the energy, you're monitoring the temperature of each individual electrode, and if one moves, it doesn't shut down the other ones. So it's a little bit more of an advanced algorithm in being able to perform denervation in a way that's effective, and we come all the way back to the ostomy as you see here. So to extract this device, we advance the wire back out, as you see here, and then we just slide the catheter back here on the wire. So it's pretty straightforward. And then we take our final renal angio right here. And the main point here is that despite performing very aggressive denervation, both in the main trunk and the branches, at most you see what we call these denervation notches, which is little bits of spasm in cadaveric, animal, and imaging data. There's not been shown to be any significant correlation with these notches with any type of renal trauma. Oftentimes if you do denervation, let's say you do it in a pig artery and you look at it afterwards, you can't even tell where you did the denervation. So the safety profile has been shown in many ways. This real quick is just us doing in the left renal artery. As you can see, we're trying our best to get these down some of these branches, and the tortuosity here is sometimes challenging, much more than anything we had seen in the first HTN-3 trial. This is a dual bifurcation supply, so we're actually going in several of these branches. The procedure with the spiral device is more time intensive than it was before because of the number of denervations performed. And I'll show you some more data about that in a second. Coming back to the main trunk, and then we're out. So as far as final angiography goes, on the left side, again, slide the catheter out in a wire. And the final result here shows a patent renal artery, again with minimal, if any, denervation notches seen. No dissections, no perforations, nothing bad like that. So there's a second generation device. We've talked about ways to do denervation therapies that would potentially be more generalizable and valid compared to HTN-3. Would the companies decide to go anywhere with this? So only a few companies remained after sort of the apocalypse of the post-HTN-3 era. The first was the Spiral HTN program, which was through Medtronic. There's also a FSCAI trial program through Boston Scientific, and a Radiance trial program through a company called Recor, and even some other smaller early feasibility stuff that has not reached the United States yet, but those are kind of the main players right now. As far as the Spiral HTN clinical program, this was devised to be a proof of concept trial, to really kind of go back to the drawing board, not try to go for market approval, but just go for the very simple premise of, can we demonstrate the ability of renal denervation to influence blood pressure in uncontrolled hypertension in a way that will be felt to be more valid to folks and hypertension specialists across the board. That was the challenge sort of issued to all these sponsors. As far as the Spiral HTN program, this is a much smaller scale study. They chose 21 sites around the world to try to make this a much more heterogeneous population that's reflective of hypertension in different populations. This also included us here at Emory. And again, this was using the spiral catheter. I won't go into the details of how the catheter works. We just talked about that. And this was the design of one of the two trials. They split this into two pathways, the off-med trial and the on-med trial. I'll tell you about on-med in a second, but the Spiral HTN off-med study was looking for patients with hypertension, but really at kind of a grade 1, maybe 2 level severity of hypertension burden. Patients who are likely just taking 1, 2, or maybe no medications, but were hypertensive on that regimen. Patients would come in, and at their first screening visit, provided they met all the clinical inclusion-exclusion criteria, we would take them off their medications. Then with my nephrology colleague, Janice Lee, she would see these patients in clinic at 2 different 2-week safety checks, given that they're off their medications, to make sure that they were not symptomatic, that their blood pressure was still within a reasonable safety range, and that was felt to be an ambulatory blood pressure monitor of between 140 to 170 and an office blood pressure measurement between 150 to 180. If they ever went over 180, they were out of the trial, kicked out. So this has been done in pharma trials before with demonstrated safety. If after a full 4-week washout, patients remain hypertensive within that zone and were willing to participate, they were then taken to the cath lab and randomized 1-to-1 between denervation and again versus a sham procedure, listening to jazz, country, western, or different types of music, and blindfolded, all both sedated to a fair degree. So patients were not aware of their treatment assignment. And then they were followed very closely, again with Dr. Lee in nephrology, every 2 weeks, up to 3 months to monitor for safety. And there were very strict protocols to demonstrate at what point it was felt that patients would have to go back on blood pressure. Medications, my apologies. And the main endpoint was safety and blood pressure reduction, if any, at 3 months. So this was recently presented in Barcelona at the European Society of Cardiology. We were fortunate to be on this publication, which was concurrently published in Lancet on the same day. So the eligibility criteria, as I talked about, blood pressure had to be 150 to 180 in the office, and a 24-hour ambulatory blood pressure monitor was done in all patients between 140 and 170. Patients could not be below or above those cutoffs. They had to have eligible renal artery anatomy, as you can imagine. GFR had to be over 45, and there were no allowable secondary causes of hypertension allowed in these groups of patients. Patients were monitored strictly for their blinding efficacy. Blinding index over 0.5 demonstrates successful blinding, both at the time of discharge and at 3 months. These patients were all completely blinded to their treatment assignment, so there was no issue of any kind of placebo effect in patients knowing what they had received specifically. As far as how the flow chart went through, again, this was a small trial, early feasibility. 353 patients were enrolled. If you really think about how many were actually screened, it's much more than that. Many patients did not meet all the eligibility criteria, and once you actually started measuring blood pressure, you get down to 80 patients that were randomized at this point. And again, this is sort of a fact-finding mission, and the number of patients that will eventually be randomized is actually over 120. But once they had suitable data, they then presented it, which was at the 80-patient analysis. 38 patients intention to treat in denervation, 42 in the sham control group, and over 92% or so of patients ended up having full data by the 3-month endpoint of the study. Based on characteristics, patients were on average about 55 years old, majority male, very small percentage of diabetic. Sleep apnea was seen in about 7 to 8% of patients. These were a fairly obese patient population with a BMI of about 30, very low incidence of any type of CAD, PAD, or stroke. The entrance office blood pressure was 160, and mean 24-hour ambulatory blood pressure systolic was about 153. So again, this is off medications. This is a totally different patient population than what was seen in HTN-3. The main number I want to point out here is that this was a much more intensively treated patient population than what was seen in HTN-3. There was a total of 44 ablations on average in this spiral trial compared to, maybe 5 to 6 denervations on each side for a total of about 11 to 12 ablations in HTN-3. So very different in terms of dosage, and many ablations that were done in the branches, for better or for worse. This was part of a gamble that at least the spiral team decided to take on based on data that they had prior to this. Medication adherence was actually measured both by urine and serum HPLC and mass spectroscopy, and there were a few patients, surprisingly, that were surreptitiously still wanting to take some medication in the midst of this trial. So you can see that a few people, about 4 people in the denervation group and About 7 people in the sham control group had some antihypertensive drug that was identified by drug testing. This was not felt to have influenced the numbers. There were a few patients that met escape criteria because their blood pressure had gone a little bit higher and needed some medication. But overall, patients about 90% or greater were off all their blood pressure medication. So what did we see in this trial? So in the systolic 24-hour ambulatory blood pressure monitoring, there was a difference of 5 millimeters between the denervation group and the control group. Diastolic also saw about a 4 millimeter drop. And again, for 24-hour ambulatory blood pressure monitoring, 5-point drop is pretty good for a therapy. When you look at office-based blood pressure, there was a drop of 10 points systolic compared to the control group, and a drop of about 5 points diastolic when comparing denervation versus the sham control group. A slightly higher amount of blood pressure drop in the office numbers compared to 24-hour ambulatory blood pressure, but again, showing statistical significance both for 24-hour and office-based blood pressure monitoring. So that has raised some eyebrows again to say, well, is there something potentially here based on this trial design? The key thing I'll say is that this is very early days, but it has re-energized a number of folks, including myself, who has devoted untold numbers of years in sort of chasing this holy grail. Safety results is another question because we were doing so much denervation distally beyond the branches, but as you can see here, there were no significant rises in creatinine, no evidence of vascular complications, no evidence of any end-stage renal disease when comparing denervation to control group. Some limitations, again, this is a proof of concept trial. This was not prospectively powered for any specific statistical significance in treatment efficacy. It was more to show difference and to really influence the creation of potential further pivotal trials. There were a few patients that still had medications detected in their blood or urine, but after adjustment of baseline blood pressure, analyzing per protocol and intention to treat analysis, the results were consistent. A main criticism of renal denervation in general is that there is no way to verify whether we destroyed the nerves unless you were to actually cut out the renal artery and look at it anatomically. There's some methods that are being studied of ways to do this, but it's nowhere near prime time. So we just have to go by our assumption that with this new technology that we did achieve full 360-degree ablation. And whether this is generalizable to other denervation technologies, that's a big question as well, because this device, again, we went into the branches. And as I'll show you in a second, with some other devices we're studying, they're not doing so. So real quick, some major differences between spiral and HTN3. Spiral HTN was a much lower risk group, no drugs at the time of randomization. This is a much more moderate blood pressure group, blood pressure of 160 off their medications, whereas patients in HTN3 had a blood pressure of 180, supposedly on 5 medications. And this was a much more experienced cohort of operators. There was proctoring at each case that was very intense. We had to take online tests, every couple months to make sure that we, still were refreshed on how to perform the procedure and with the protocol. And this was a simultaneous ablation system compared to HTN3, where there was not much proctoring. There was only main artery ablation. And again, a big difference in dose effect, 11 ablations compared to 44 ablations in the 2 trials. So in conclusion, for the hypertension off-med trial, this was just a biologic proof of principle study, but in mild to moderate hypertensive patients, there was a significant drop, clinically meaningful at 3 months, with no major safety issues, and this will inform the design of a larger pivotal trial which has already been approved and given the green light by the FDA for the spiral catheter system. So look to that in the next year for a much larger trial to evaluate the effect of this catheter in hypertensive patients. What that trial will look like, we don't quite know, but should be coming forth in the next year. Now there is an on-med trial that I also mentioned here in the lower square, which is looking at this device in moderate stage 2-3 hypertensive patients. The main difference here is that these are patients who are taking anywhere from 1 to 3 medications that have to be within this group. Thiazide, calcium channel blockers, ACE or ARB, or a beta blocker. Blood pressure criteria are exactly the same, and drug testing is also performed, and they're randomized in the same way. The key is that these are patients with a higher hypertensive burden, and the interesting thing is that this study has actually randomized in a much slower fashion than off-med. And off-med, they really used a new modality in going to social media to try to inform patients of the existence of the trial. So it was much easier to extract patients because patients would come and find you because they'd see this on Facebook. But the number of patients that would similarly find you with this trial has been a little bit slower. So this study should complete randomization hopefully by the end of this year. Again, we kind of went into the inclusion-exclusion criteria very similar to what was seen in off-med except for the medication requirement. So in going from there, I want to just briefly touch on some trials that we will be participating here at Emory or are just now participating in. These are all available, some now, some in the next few months. The first is with the Paradise system, which is an ultrasound-based denervation system. The main difference here is that this is balloon-based and actually circulates water cooling inside the balloon and then applies heating through an ultrasound element, which you can actually dial up or down at a varying distance. The distance that they're going to use in the trial is similar to what was done with radiofrequency ablation, but you get this far field heat effect and you have safety profile with cooling within the artery. Their shtick with this trial is that because it's ultrasound, you get a rotational, full concentric denervation around all of these nerves. And they are just focusing on the main renal artery. They will not be going into the branches. There's an interesting video here that shows in a thermal gel model. I'll kind of cut through to the interesting part of this. So if you look at this in concentric fashion, as they turn the system on in a thermal gel system, you'll actually see the denervation occur. And if you actually touch this, it's very, very hot. You don't think anything's happening, but you can see here that you actually get a full concentric treatment effect around the kidney artery. Whether the nerves traveling through those bundles will be enough compared to the distal ablations that were done in the spiral trial will be sort of the very interesting question if this system shows clinical efficacy. I won't go through all the details of the trial design, but it's very similar to what Spiral's design is in that there's a solo cohort, which is essentially an off-med trial, and a trio cohort, which is an on-med trial. But the big difference with their on-med trial, which is called Radiance Trio, is that they are putting all the patients on the same medication. All these patients will be put on X-Forge HCT, which is a triple therapy regimen. And the trouble that they've seen is that they get these patients that are referred as being resistant hypertensives, and once you put them on this medication, a lot of them drop their blood pressure. So that this trial, just like on-med, in Spiral has been slower in enrollment. Their solo trial should complete enrollment this calendar year. Trio, they're hoping for completion sometime in mid-2018. Outcomes are very similar that they're studying compared to the Spiral trial, except that this is actually statistically powered for treatment efficacy, which will be interesting to see once they get their numbers. And again, as I mentioned, they're going for full 360 concentric treatments along the course of the main renal artery, but nothing at all in the branches. And Medtronic was acting on data that was seen in a pig model, as well as recent data just published this month in human data, showing that the more distal ablations you do in the branches, the more blood pressure lowering you get. So whether this Paradise system by Recor will show the same effect with 360 concentric ablation versus Medtronic system, we'll have to wait and see. The ROX coupler is another device I'll tell you about really quickly, which is aiming for a different population of patients. Isolated systolic hypertension, which some folks describe as structural hypertension, patients who have significant stiffening of the arteries. And this is much more prominent in the more elderly population. So the intention with this device is to go through with sort of a ultrasound needle and actually create an AV fistula between the iliac artery and the vein to essentially create a pop-off valve for blood pressure to shunt through the iliac artery into the vein and to increase arterial compliance and decrease vascular resistance. And it's an immediate effect. When this ROX coupler is closed, the blood pressure is 180, you open it, and you see an immediate drop in blood pressure. Now, as you can imagine, there's a lot of questions and concerns about whether this is safe or not. But this is what they've seen on the table. You have the blood pressure at this level, they put the shunt in, and all of a sudden you see a blood pressure drop. It's just a physical phenomena of what they can accomplish with the device, and they have already studied this in an early feasibility trial published in Lancet 2 years ago, which did show a significant drop in blood pressure at 6 months in the AV coupler group compared to patients in the control group, both by office-based blood pressure here on the left and on the right bars here in the AV coupler versus control. The main concern, as you can imagine, is that you can get venous stenosis because of this increased circulation through the iliac vein. But a lot of these patients, when they saw that, they monitored for this in the trial, they would just stent that, and there was very little incidence of any problem related to that device. There will be a US ROX HTN trial that's forthcoming. We will be participating in this. At Emory, it'll be a 1-to-1 randomized sham-controlled trial looking just for isolated systolic hypertensive patients. The last device I want to tell you about is a Mobius HD, which is a little bit dear to my heart, which is looking at the carotid baroreceptors as a treatment target. The baroreceptor is located in the carotid bulb, sending nerve signaling to the nucleus tractus solitarius in the hypothalamus. And the goal here is to affect the baroreceptor's physiology, which is mediated by stretch and not really by blood pressure. And this is the little device. It kind of looks like a stent, but as you can see, it's got these wide open cells, comes in 3 different sizes. And the intention is to change the shape of the carotid sinus in the diastolic phase and to fool the brain by inducing a little bit of stretch into making the brain think, because of the stretch between these 2 posts, that the artery has been stretched this much, and giving the brain a signal that the effective radius is much larger than the actual radius of the untreated carotid artery, and trying to change the pulsatile wave during diastole. The delivery system is very similar to active carotid stent systems that have been on the market for 10+ years. And these are patients very carefully selected for the absence of carotid disease. We place the device really with no distal protection because these patients don't have any embolic disease. That was felt to be the safest approach by the investigators. And then to increase the signaling through this nerve. The first device placed in human was actually done here at Emory. This was actually a patient who was identified by a cardiology fellow like yourselves in clinic, sent to us, and that patient really sort of spurred the interest in this trial and has led to this trial being published actually this month in Lancet. Their CALM clinical studies have been evaluating this. A first-in-human concurrent study in US and in Europe just published this month was the European data. This is an open-label first-in-human trial looking at unilateral carotid deployment of this device with safety at 6 months as their primary endpoint. 86 patients were assessed for eligibility, with 30 patients that had an attempted device implantation. Fairly sick population. Office blood pressure was 184 on an average of 4 antihypertensive medications. No major adverse events except for those related to hypotension, which was interesting. The change in office blood pressure that was seen was fairly dramatic. As you can see here, blood pressure drops of just over 20 points systolic as you went from 1 month down to 6 months. Again, this is just a single-arm study, no control group, but just in terms of thought-provoking data, very pronounced blood pressure drops in this study. 24-hour ambulatory blood pressure monitoring also showed a very significant drop at 6 months of 20 points in blood pressure. And the thing that's different about this device is that this was done with the patients on average actually coming off a half medication equivalent and actually in a reduction in overall dosage, which is not seen in any of the other clinical trials. So that's generated a lot of clinical interest. This has actually led the FDA to approve the design of the CALM-2 trial, which will be a pivotal trial similar to OnMed or TRIO. which will be a randomized, also sham-controlled trial, which we hope we'll see by the end of this calendar year or in 2018. So in conclusion, we can no longer assume that denervation has no effect on blood pressure after the results of spiral HTN off med. But again, it's very early days, early data. There are several trials that are ongoing to evaluate this in more intensive patients, also with new technology. And we are very interested to see what the spiral HTN FDA pivotal trial will look like later on, hopefully this year. There are also alternative approaches that have been studied all along, including carotid baroreceptor amplification and AV fistula offloading. Whatever you think of either of these two, they're out there. And patients, and they're looking for patients that are much sicker and have less options than the patients in these other denervation trials. So this has sort of been my path in studying catheter treatments for hypertension. This is me after HTN3, drinking the Kool-Aid or something equivalent to that. But my hope is that I've at least achieved some progression to the mad scientist phase in the Simpsons pantheon. And hopefully, as we get more data, we can actually relegate this to larger clinical trials and potentially see this as a tool in the armamentarium of treatments for hypertension in general. But my main point that I want to issue to all of you listening out there or in the audience, that if this works, can we afford not to study it? After HTN3, it's been very, very difficult to find patients enrolled or referred for these trials. But given the off-med trial data, what I would ask to all of you is that if this works, given that we're here at Emory at a scientific institution, think about these patients when you see them in clinic or in the hospital. Feel free to give us a call. This is our interventional cardiology research team's information. I want to give a shout out to all these folks at the bottom of the screen that have put a lot of hard work into this trial and into the ongoing trials that will be forthcoming. So please give us a shout if you find these patients, and hopefully we'll have some more interesting numbers in the years to come. Thank you for your attention.
I think given the hour, we'll just do one quick question, and I'll shoot that one to you, and that is, so at the end of the day, if it works, great, but what about the costs, right? Because your competition is really some pretty cheap drugs, and you get into sort of philosophical discussion of patients owning their health issues, et cetera. What do you think the insurers will pay for this? I guess is one of the reality questions.
So we have to look to the folks across the pond in Europe where this was commercially approved, and it is a big question. The cost of this is not negligible. In some models in other countries, there may have been more of a pay-to-play type of model where those who had the means, sought this. In HTN3, we had some patients that tried to convince us when they didn't qualify. Well, hey, what if we had one patient I'll tell you about that offered to fly our team down to the Caribbean to bring the study device with us and perform this. And we can't do that. But there are patients that, with more means that potentially could afford this. But what about those patients who don't have the means, that may not be insured? Well, it brings up another very interesting question, which when HTN3 was published, when HTN2 was published, there was some quality of life and also cost effectiveness analyses that were performed that said if you can drop blood pressure by, well, at that point it was a blood pressure drop of 20 to 30 points, what type of effects do you see in the long term in terms of reduction of hospitalization for heart failure, hospitalization for myocardial infarction, for stroke, for the incidence and need for dialysis in patients 10, 20 years down the line? And that's where this will be a very interesting question, because if you can drop blood pressure in 5 points or 10 points in your patients in the clinic across the board, what type of health benefits do we see as a system or a society in downstream adverse events from the morbidity of hypertension? Spend a week in the Grady ER and you'll spend a lot of time with the downstream problems of hypertension. And that's going to be a big question, that if this, and this was actually a discussion that came about in the Barcelona presentation a couple weeks ago, where some of the panelists were already talking about, well, where does this look like in the rank order of the treatment armamentarium? We're not there yet, but If the future studies show that this blood pressure drop is real, I think the payers are going to be asked that question, and it'll depend on what our health model looks like. If you have a panel of patients and you're following them for life, and you have patients that you know are non-compliant, does it behoove us to actually get them to this type of therapy so we don't have to deal with the problems of their non-compliance and the hypertensive morbidity down the line? That's an argument. I'm not saying that that's fact, but I think that'll shape some of the debate of this to come.
Okay, well, lots of more good questions. You hopefully will be around a little bit to talk to folks, but thanks so much, Shannon. That was great. Thank you.
Thank you.
The preceding program is copyrighted by Emory University.